all chronic pain situations. The support group is really important as well, because then you can relate, you can find people who relate to you. Because it's very difficult for family members to understand that you could have a disorder that's so severe that you could be disabled, and yet there's no signs. You can't see anything. You look completely normal. That goes for headaches the same. Headache is the same kind of situation. A person with headache is going to look exactly like a person without headache. And for the family, it's very, very difficult to understand that they're missing birthday parties or they're missing celebrations because of their headaches. So what are the outcomes? So it's very difficult. It's very, very difficult disorder because some people will stop having burning symptoms spontaneously, but there is no length. I cannot tell them. Most people stop having burning in 2 years or 3 years or 4 years. It's completely variable. Some people never stop. So I cannot give them any kind of timeline to grasp to or to be patient, because most people don't have it anymore after 5 years. I can't give them that. And the results, the reality of it is that very few people completely go to, I don't know exactly the percentages, but the treatments are such that not everybody goes to zero, even with the medication. And that's why the expectations have to be realistic when they start treatments. I don't know if I'm going to be able to get you to zero. What would you be happy with? Would you be happy with 50% decrease? And usually they say yes. And so the goal becomes 50%, which is achievable. And if we get better, it's great. Then they're even happier. And very seldom is it less than 50%. At Stanford, they're doing a study on nerve block. We haven't done enough patients. We'll see what happens. There are also some people who do stellate ganglion block in the hopes that part of the pain is sympathetically mediated. Again, I don't have a lot of results for that. It's pretty on the cusp. It's more like a Hail Mary for people who really want a procedure. If they really want a procedure, then these would be maybe reasonable procedures because they're relatively simple and low risk. But I don't have data. Maybe next year I'll have more data, because we started doing it at Stanford. I started sending patients who were non-responders or poor candidates for medications for nerve blocks. So the complications of this disease are few. I mean, it's not going to kill them. It's not going to cause cancer. It's not going to kill them. I want to tell them that up front. So at least that is alleviated, because it's always in the back of people's minds. I mean, to you, it's not. For you, it's not. It's like, how can they think that? But they do. So, difficulty falling asleep, which increases their depression and anxiety. If there is an underlying depression and anxiety disorder, it gets worse. They have difficulty eating, so they will not go to the restaurant, they will not go to parties. So their social life will decrease slowly, which is increasing their depression, anxiety, and decreasing their quality of life. So it's very, very difficult to live with. Very, very difficult. So a lot of people feel like they won't be able to go back to work. It's surprisingly, even if people have a 4 out of 10, which doesn't seem all that bad, the disability associated with this syndrome is quite high for some people. And you could frankly discuss that with them. I mean, I discuss this with patients all the time. And that's why I was bringing up counseling as one of the palliative treatments. You have to send those patients with chronic pain to a psychologist, and most particularly a pain psychologist, because they will be able to give them tools to be able to tolerate their pain and to maybe change the level of their pain and accept their pain. And they will be able to, particularly for our focus on the physical pain, they focus on the emotional pain. And together we have better results than if I'm not there alone. The limitation is financial. Very few people's insurance cover psych, and that's a real problem for me. Because my hands are kind of tied if I cannot send my patients to a psychologist. I know the results of my therapy will not be as good if they don't see a psychologist. But people have limited means, and they choose. And some people choose to go, and some people choose not to go. There's not much I can do. So if they choose not to go, I discuss this with them, and I give them classes that they can go to, like mindfulness-based stress reduction classes that are relatively inexpensive and that they can find in the community. And those would be definitely better than nothing. Stanford has catastrophizing classes. Part of the disability index comes from catastrophizing. So there are people who are catastrophizers. If they have a small cut, they're going to worry about it being infected. If they have a pain inside their abdomen, they're going to, for sure, have cancer. There's a type of person that will be a catastrophizer. So for those people, they have classes. And they're also very cheap. So you can recognize if the person is going overboard in terms of, oh my God, you know, what is this going to do to me in 5 years, 10 years? How am I going to be? Am I not going to? If you feel like, it actually would be nice to read about catastrophizers, because catastrophizers and somatization, and people who somatize are the most likely to get chronic pain. Like if you have patients with migraines and they have occasional migraines, one of the risk factors for people going from chronic migraines to, from acute migraines, episodic migraine to chronic migraine is if they are somatizers and catastrophizers, in addition to obesity and low socioeconomic factors. So it's huge. So they really need to be addressed. And low cost, so mindfulness-based stress reduction and catastrophizing class in the community. And those are a couple $100. Any questions? Yes?
So when patients come in, usually they complain about the whole tongue being burning sensation, or it could be localized?
It can be localized. It can be generalized. It can be localized. It can be the inside of your cheek, the back of their palate, the front of their lip.
I have a patient who was referred to me because complain on one side of the tongue where the implant were placed.
Yeah.
And the dentist basically has done everything, changing even the crowns, putting temporaries, and all that hasn't changed anything. And I said to him that, this is a nerve problem. So you got to see somebody that has nothing to do with the implants. It appears that he had some problems when they were placing implants, so he's depressed and taking medication already.
So when the implants was even not covered, he had problems?
Well, he basically has been complaining about some problems around the implant all the time for 5 years to the dentist. So he has done changes. Basically, they sent it to me for a graft. So I'm doing that, but I told him the graft is not going to take care of the tongue.
Yeah.
That's something else. You got to address that with your doctor. And he's taking a list of medications and all that. It's just one localized area around the implant that he's always complaining.
Around the implant.
Around the crowns. I mean, basically.
Yeah, well, that could be just general. That could be just a neuropathic pain. It doesn't have to be burning mouth. If you have burning pain after treatment, and it stays there, it's probably more likely to just be neuropathic pain following dental treatment. And then it would be treated. It wouldn't necessarily be treated with clonazepam. Clonazepam is really specific for burning mouth. For regular neuropathies, then you would be more like gabapentin only or tricyclics, or any other anti-epileptics for that matter, Keppra. You have a lot to try, so it could take a while, but that's definitely the way to go. But you can also try to see if, does topical help? Does topical help for him?
Anesthesia. Anesthesia. I haven't tried it yet.
Yeah, try that because there are also some compounds that you can use topically. The same compounds, but if you get a good response from a local anesthetic, then you know that there's a certain peripheral mechanism. It's not just central. So if there's a lot of peripheral component to the neuropathy, then you can make a stent that holds the medication in place with gabapentin, benzocaine, and so on and so forth. So it's easier because they don't have any side effects. Okay? Any other questions? So, yes?
You said these medications are very expensive. Roughly how
Rallies? God, I had looked it up and I don't remember. But do you have Hippocrates? Hippocrates on your phone? Well, Hippocrates has the medication. It also has the price. And I also have this app that is a prescription app, and I can give you the name. It actually tells you which pharmacy has the cheapest prices. And it can go from $19 to $270. I mean, the range is huge.
We need it.
Yes, I'll tell you what it is. It's a
I'm fighting
great
my
app.
interest for medication.
Yes, it's a great app. Yes, and sometimes it says you have to do a coupon, so you know but it's very useful, and it's not always like the CVS or Walgreens that have a huge variation between the two of them. I didn't know that. I just recently found out, so it's a good one. So this is a website that talks about Burning Mouse syndrome that you can direct your patients to. Again, you'll get the copy of this. You don't have to write the link. You'll get the presentation. So this is good information, solid, clearly explained, that is going to help them understand what their disease is all about. And it comes from a reputable source. So rather than sending them online and they're going to maybe see some crazy treatment out there that they're going to grab on, send them to reputable sites that they can have good, valid, evidence-based information to refer to. This is just an example. I just found it very, very clear. And if you have any particular questions or problems with one of your patients, again, you can always email me if after the fact you read something and you want to see if it's a new treatment. I'd look into it. I'm always really interested in new and alternative treatments because I find that I'm always learning and people are studying this. I'm not a researcher, but there's a tremendous amount of research done on pain. And sooner or later they're going to have something that works better than clonazepam and gabapentin for this particular treatment. The response to clonazepam actually was a blessing in disguise. I mean, in a way, not a blessing in disguise. The response to gabapentin is the reason why they thought it was a psychological disorder, because it's a benzodiazepine. So they figured if it responds to a benzodiazepine, right, it has to be psychological. It just so happens that clonazepam is the only benzodiazepine that has also some anti-epileptic properties. So if you give those patients Valium, they're not going to respond. If you give them Xanax, they're not going to respond. So obviously it is a benzodiazepine, but it's probably not the anti-anxiety effect that we're harvesting to treat this disorder. So I'm open for questions. I'm almost caught up. And if there are no more questions, I'll just give the mic to the next speaker.